I'm very excited to be here. So we'll be speaking on ACL tears can heal without surgery. The game has changed. If you don't know much about me, my name's Kieran. I work as a specialist physio based in Perth. I do offer telehealth all around the world and to the other side of Australia as well, and often in Perth as well because it can be difficult to get in the Hillaries. I also run a consultancy company of academics and expert clinicians where we mentor, train, run professional development, latest evidence, and second opinion for patients who may need it too. So you may recognise some of those faces from Perth, Curtin and Notre Dame. If you don't already, feel free to follow me on LinkedIn, Dr. Kieran Richardson, for professional content. If you want meme content, then you can follow me at Global Specialist Physio on Instagram. There is meme science, so if anyone wants to debate whether we need to use memes in scientific literature, there is precedent here. So here's a meme that I've got for you that you may have seen. So, yeah. So in terms of the outline from today, there's, I guess, three main themes I want to go through and obviously have some time for Q&A at the end. But I wanted to cover the current best science, the fact that ACL tears can heal, but not all of them, and I guess how teamwork can look and how, from a multidisciplinary point of view, like this conference, how we can work as a group of professionals to get the best outcome for an individual patient. So if we look, I guess, in the current best science and in terms of the main two views or themes that you would generally see, obviously you have this traditional orthopaedic view, and it's embedded, I guess, in orthopaedic training. There's some studies that would say there's almost their own guidelines and tradition, and it's more of a diagnosis and management by image. And then typically the studies would be a retrospective analysis of surgical data, and there does seem to be a focus on failed non-op studies. And then you have this other view, which is, I guess, what I would consider to be a multidisciplinary point of view. This is an example of one, although it's not the only one, where we have two physio experts and two surgeon experts in the Canon study. And it's, I guess, an interprofessional consensus. And then there's a systematic review or metadata view. And then we're looking at the best studies comparing surgical versus non-surgical with respectful skepticism and an individualized patient-centered approach. I actually believe that it can be a confluence of these two, and we can kind of find a way to meet in the middle. The challenge is whenever I'm reading a scientific paper, I first go to the methods, and I'll be looking at the non-surgical comparison arm. And so a very key question I want to leave with you guys, whenever you're looking at any new intervention, whether it be an exercise strategy to treat pain or injury, a surgical management, an injectable management, you have to ask yourself, what is the quality of the non-surgical or exercise therapy comparison arm, if there is one? And that's where it gets a bit more interesting from a research point of view. So obviously, if we're talking independent variables, we can have a variable like surgery and then a treatment or variable like exercise. To separate at a base scientific level, we need to be having two groups that are pair matched, large enough that then we can, I guess, generalize these results to the population. The problem is when we start to look into a lot of the research, there does seem to be two studies that would be surgical versus surgical. But when we whittle down the studies, and a very good example of this is a research group of surgeons by Blom from 2021, where they looked at, for the knee specifically, reconstruction, meniscectomy and repair. There was 3 RCTs where we compare surgery to physio, and the outcomes are very similar. This doesn't mean that surgery is not necessary and there's select patients that we can't use it for. It's just that the general outcomes seem to be very similar when we treat people with exercise on its own. So sometimes there's these phrasing and these narratives that, I guess, ACL reconstruction is gold standard, but then when I'm always thinking, okay, well, what are we comparing that to? Is there some other comparison arm that we can use? And I guess it can be difficult at the front end in a real world or clinical scenario when this is a I guess, a methodological issue when you have the conclusion from this paper here. It's a famous one by Sanders. And the conclusion was that if we don't operate early on patients after an ACL injury, they will basically need a total knee replacement as soon as possible. And they're going to have one, it's going to be fast track. So I will see and hear patients that have been told this, like, if I don't operate on you, I'm going to need to do a total knee replacement in a year. The problem is when we start to look at, this is a similar theme that I see in the research where we have a lack of a comparison. So we can't really say that until we have two groups operating at the same time at the start, which I'll show you. So this is similar theme that early surgery is best. It's going to prevent meniscus tears. If I don't do the surgery, you're going to have additional meniscus tears and you're then going to get arthritis. And it's the issue then is that we don't actually have a comparison to compare it to. So I'll put it to you another way. So if we have these two treatment arms in one study, a person gets a surgery, they then get excellent rehab. We then follow that group up over time. We then have another group who doesn't get anything. They're not exercised, their knee is not stable. We let them roam free, out dancing into the wilderness, this kind of thing. And we follow them up at an endpoint. We're not really comparing the two groups in an identical way. So we will be comparing apples to either nothing or apples to oranges. And so that's a poorly designed study, and that would be what we would consider to be bad science. But what we can do is we can try to separate a distinct difference between the two treatment arms. And so we have one group that gets elite surgery and elite rehabilitation, and then we get another group who gets elite rehabilitation or a brace, or both, and then we follow them up over time, and then we, across different variables at a future time point, we compare apples to apples. So this is good science. This is good research. If you want to make it even better, you can randomize the patients. So we can't kind of pick and choose the patients who we think are going to do really well. They're similar exercise level. We make sure they're getting really good high quality rehab in both groups. That's good. That's a good study. And so essentially when we're talking about this topic of meniscus tears, there is going to be, as we age, sadly, meniscus tears that occur over time in both groups. In terms of the rates, those would be pretty similar when we look at comparative high-quality studies. So this paper by ECAS, a surgeon from Scandinavia, and another surgeon and two physios, they said, well, look, it's actually very difficult to predict whether someone is going to get more additional meniscus tears over time compared to someone who has early surgery versus rehab. The other issue, which is becoming a bit more of a hotter topic or something that we need to question, is this idea of osteoarthritis post the injury. It's likely that there's like a 50% increased risk of getting osteoarthritis after an ACL injury, but only about 50% of those patients will actually get pain associated with it. So I guess that's the good news. But when we look at the metadata, this paper by Kate Webster and Ferrero, there does seem to be pretty similar outcomes in terms of osteoarthritis. So we can't necessarily say that by operating early, you're going to reduce the risk of arthritis for patients. And I think that we need to be communicating that to patients early. This is a very good infographic that I've come across. It's probably ridiculously hard to read. And it's by Patrick Owen. But I guess the key summary, some new information that we can bring to inform clinicians who would be treating ACL injuries on the front line, is that if you have persistent instability, you are probably going to perform better with a reconstruction. And that was based out of the SNAP trial of patients who didn't receive early rehab but had persistent instability. They were treated with either rehab at 6 to 12 months or they were treated with surgery. The patients who had persistent instability, they were better off with surgery. There's also been some other high-quality research that suggested that at least 25 to 30% of ACL tears can heal if we rehabilitate them early. And so this is something that we can communicate to patients as a part of a shared decision-making process. So I guess I like to think of it like a train journey, and I'd communicate it like that to patients. So some patients can have their ACL tear heal sufficiently, no question. Some can cope without it. There will be some patients who will need reconstruction. and there'll be some patients that will adapt. And there's a strong argument that the patients that adapt would be close to 50%. So it's rough to tell every single patient that we're going to, whatever treatment strategy we use, we're going to give them a brand new knee that is going to then get them back to sport 100% of the time, because the metadata doesn't suggest that, sadly. And so at the front end, I'm communicating this to patients as a part of a shared decision. It's also really hard when you look at what cohort are we talking about. So we have to kind of define the cohort, and most of the patients that I would see and speak to would be at a general population level. And in saying that, a lot of them are influenced by the elite level athletes. And so there's this idea that if you want to get back to pivoting sport, all the elites do it, and that is what the cultural trend is. And I've heard it said that there's no studies that compare elites to with surgery or no surgery, and that is actually not true. There is this paper by Mickelbust from 2003 where they looked at European handball, both male and female, and they showed very similar return to play rates in both groups. And so I guess then bringing it back to a single case study, this is probably one of the more remarkable ones. I'm not sure if you've heard or seen of it. This is Mitch Short. So he played for the New South Wales Waratahs. He was playing in a game. He changed direction. His knee popped, and he said it was really painful, and he kept playing. He actually scored a try to draw the match. And then after the game, they went in, they felt his knee. They said, look, it feels loose. Let's do an MRI. They confirmed a full thickness rupture. In saying that, he had very little pain. And so they actually kept up with his rehab, doing prehabilitation at the very least. And he said, look, I honestly feel totally fine. My knee feels good. And 2 weeks later, it was decided by the medical team that he was actually fine to play. And clearly it wasn't his taping job, because that was pretty dodgy. So he played 60 minutes in his first ever run-on game, scored a try and got man of the match. Now, I'm not suggesting you do this with patients, because I think, personally, I think it's pretty rogue, but it's very rogue, but it shows what is possible. What's then most remarkable, they did a follow-up MRI at a year, and his ACL had completely healed. And it was a part of being transferred to another club. And this is Dr. Sharon Flahive, a sports physician, and she goes on in this Knee Guru's podcast to talk about how it wasn't actually that rogue. They went through a deliberate, specific strategy. They've informed him of all the risks and everything. And I guess it could be used to change the narrative. And I guess it's probably just that elites, there's not enough of them dare to try, at least waiting, which would be a key message of mine. So the other thing is this concept of meniscus tears and what are we doing to treat them. And I guess another key message for me to you guys is that, as I guess predominantly exercise therapists, people treating other patients with pain and injury with exercise, you have to know that a lot of patients with either a chronic degenerative or acute meniscus tear can do very well by treating it with exercise alone. This is not saying that no one ever needs meniscus surgery, but it's just the rates of meniscus surgery are very high. And I think it is possible for us to believe in ourselves to tell the patients that we can treat them with exercise alone. And I guess it's really hard and kind of damning when you look into the studies showing that particularly meniscectomy has got level 1 evidence of harm now. That means that patients who've had a meniscectomy, particularly in the older patient, they have an increased risk of progressing towards osteoarthritis and then a total knee replacement. And so I've listened to some podcasts. That's not my meme, by the way. That's actually the La Trobe University. And I don't believe that meniscus surgery should be stopped or cancelled in any way. There's absolutely patients where it's beneficial. But we need to slow down the rates. There's no question. And so that we have these good, very, very good empirical research that's showing that has been the case. And I think there has been a slowing down of that within Australia. And this is a cool podcast I'd recommend you guys listen to, the Joint Action podcast with Teppo Jarvin and Professor David Hunter. There has been a slowing down of meniscectomy, but then a quite drastic increase in meniscal repair. The issue with that is it's dichotomous. So we really only, for the patients, oftentimes they only have those two options. And I do send patients for meniscal repair. But the thing is, there is this third option that may be the dominant option, which is exercise to treat the meniscus. And so specifically talking about young active people who have an isolated meniscus tear, this paper was released last year that showed that 75% of patients with acute meniscus tears don't need surgery and 25% will. And then talking about the specific type of meniscus tear, it gets quite hard because the larger tears don't seem to correlate to symptoms. The location of the tears don't seem to correlate to symptoms, and there's a lot of patients that do well. And so this was followed up this year where they showed that actually if you repair the meniscus versus doing a meniscectomy versus treating it with exercise, it doesn't seem to change the rate of osteoarthritic progression. It's the same. And so we can confidently say that to patients based on this level 1 study. There's also this idea, which is pretty common and prevalent throughout the musculoskeletal system, that patients can have incidentalomas, tears that occur in the shoulder. You can have disc that looks big on scan. The patient has no pain. It's pretty well known in exercise rehab. It's the same with knees. So patients can have large tears and even quite substantial tears with no symptoms. And
the other thing, this is the first paper I'll talk through, which actually was completed in 1996 by a Japanese group where they did a second look arthroscopy. So they diagnosed patients after an ACL injury early arthroscopically. They went back in at 3 months after the patients had completed the rehabilitation. 20 of the 25 ACLs had actually healed, and there was also a high percentage of healing in the lateral meniscus, although not all of them healed. And then 58% of the medial, but none of them healed partially.
So what kind of bracing strategy did they do? So this is, I guess, a bit of an insight into this theory as to how we're going to treat patients. Essentially, if the ACL's torn, you do an anterior draw, it feels lax. So the Japanese did the reverse. They put them into a posterior draw moment. And so that was their reckoning, and that they did the reverse for a PCL. So when they went in, they actually did test it with a probe, and it felt stable. It felt solid of the 25. And again, that's not saying all of them can, but a lot. And so when we're having a meniscus tear that occurs with an ACL injury, when you look at further analysis of the best studies, actually just leaving the meniscus at least till 3 months gives the patients a better long-term outcome. If we operate on them early, they'll then be in a reduced weight-bearing period because of the stitching that is put through the meniscus. And so that then affects the potential to do rehabilitation and obviously assess whether it heals both the ACL and meniscus. So I guess from a non-surgeon point of view, and this is what they spoke about in this podcast when the Canon trial came out, and they said that they have this hour-long conversation. You can find it on BJSM. They talk about how do we treat ACL and associated injuries. It was actually Iwa Ruse who came up with the GLAD program, and she says, look, it basically boils down to signs and symptoms. If the patients have symptoms that persist despite having done exercise, then we can move them on and we can tick that box. If not, then we can play on. And I would say that specifically, if I'm talking large displaced meniscus tears, bucket handle, root, flap tears, these types of tears are going to have a significant increased need for surgery. But I guess from a research point of view, which we can discuss in the Q&A, that's where it gets more interesting. Okay, so if we're talking about whether ACL tears can heal, I guess we've been saturated with this meta-narrative that they can't. And if you just type into Google, can ACL tears heal on their own? An ACL tear cannot heal on its own because there is no blood supply to the ligament. And so when I read that, I think, okay. And as a natural thinker, I just start thinking about that a little bit longer. I think, well, if there's no blood supply to it, how does it actually grow in the first place? And then we hear this other stuff that it cannot heal on their own, and it's this been this narrative that has pervaded. When you trace back through where this idea came from, it comes back to this study where they actually resected the ligament in dogs, and then they went back in again and looked and to see whether there had been any healing had taken place, and there hadn't been. None of the ACL tears had healed at all. Probably what they needed to do was apply was apply a wobble board or some strengthening program or put the dog into a brace. And this is where it's all fallen down, is that as soon as the injury happens, we can't just leave the person. We have to try to stabilize it. It's a bit rough on the dogs for not having this done, but essentially in order to try to either work out, is it the positioning of the brace or is it the mechanical stress that we're putting through the ligament, this is what should have been done and probably could be done both in animals and humans. So where did this all start for me? So how did I get to this point where I was starting to look into it? I had these two contrasting cases that I saw in pretty quick succession that, honestly, I was probably just minding my own business, not naturally someone who wants to talk more than I need to, but I had these two cases here in Perth. This first patient, she had an ACL reconstruction day one after the injury. She had a contaminated hamstring graft, which resulted in a LARS being performed. She then had a cyclops lesion removed arthroscopically. Then she had a synovectomy, a partial lateral meniscectomy. She then had a revision because it was felt that as her dial test was positive and her graft was lax, that she needed that replaced and also a posterior lateral corner stabilization. So she had that performed, and so she was into her, she had 5 surgeries. She also had an infection along the way. And then the day after her 5th surgery, her knee buckled and she tore her MCL. And I saw her walk into my clinic on a 4-wheeled walker. And so as someone who was in their mid-30s, it was a bit of a surprise to me. I was thinking, well, why is this person? And she was very despondent and actually, as a bit of a sting in the tail, she's just torn her other ACL. So this was about 8 or 9 years ago. And she's decided to choose a bracing strategy first. We did get her back, but it took about 18 months of solid rehab. So I saw that case, and then I had this other case who she came in and she was adamant that she didn't want surgery. She was just, I don't want surgery. My friends have had it. I don't want to do it. And so I looked into the research and I started thinking, okay, well, what does the studies show? And then I started to look into these meta studies, and I said, okay, well, let's go through what your options are. We'll do a rehab program. So I did my rehab program, first one I've ever done. And then it was 4.5 months she returned to play. And at long-term follow-up, she was fine, and she returned to A-grade amateur field hockey. And so I started to look into the research and think, okay, well, this is pretty cool. Like, this is something that we can definitely help patients with. So prior to COVID, I managed to fly over to Sweden and meet Professor Richard Frobel, who was the lead author of the Canon study, and actually Stefan Lohmander, who was emeritus professor of orthopaedics, who was Richard's supervisor for his PhD. And I sat down with both of these guys and I interviewed them for about 2 or 3 hours. And I just asked them every single question I could think of based on the comparative studies. And Stefan, interestingly, when I asked him, I said, look, Stefan, what do you tell patients? Because he's primarily a researcher, but he does do occasional surgeries. And he said, look, Kieran, it's a very different system here in Sweden. The Richard Frobel is what we would consider a specialist physio or an orthopedic non-surgeon. That's what they call them in Sweden. And he said, look, I tell patients to go away and do at least 6 months of rehab because I can't promise them if I operate on them early that they're going to have a better long-term outcome. And when he said that to me, I was like, okay, that's pretty interesting. And then, so from that time, I just started to assess and treat patients and try to get the messages out there, make patients informed. And then a surgeon here in Perth started sending me ACL patients. I was thinking, this is pretty cool, asking for my opinion. And then I called him up and said, look, why are you sending me patients? And he goes, look, I believe in it. I believe this is something that can work. At the very least, they need to do prehab. And he goes, how about we'll do an MRI? Because in our training, we're told that basically if we don't operate, the patient's going to get additional meniscus tears due to ACL insufficiency. And so I just started doing repeat MRI in collaboration with the surgeon, and I started to see large amounts of healing. So at least 50 to 60% would heal if we could catch the patients early enough to start stabilization. So what have I seen? So I've seen healing where it looks black and straight. I've seen where it's more curved. I've seen it thin, and I've seen it not heal at all. And so talking about it like this, it might sound mind-blowing. Now it doesn't really surprise me. But again, it's kind of like, is that ligament functional enough for the patient? Okay. So just going into pathophysiological considerations, there's been some recent research that highlights that the body will attempt to heal the ACL early. particularly the proximal tears. The blood supply is better at the top and almost double the middle and almost triple the distal. There was this Japanese study that they looked at superb microvascular imaging, which is like a high-quality ultrasound, and they showed that actually straight away the body will start to put more blood flow to the ligament. I guess the challenge is, has the synovial envelope around the ligament stayed intact or not? And oftentimes it does. And so also with that, they've done some anatomical studies where they've got torn patients who haven't received any treatment. They've looked at the stumps under microscope, and they've seen that actually you can get collagen that would predispose to someone having a potential bridge formation of a tear. And then there's this whole idea of mechanical transduction, which famous sports physician Kieran is very passionate about. And basically, if the ligament is torn, once we start putting weight through it, from a strength and conditioning point of view, you can actually get additional collagen that can form between any cross fibers that have been built, or if the ligament's close enough, we can see that the ligament can start to take its normal shape in a lot of cases. So I guess an example of this you may have seen on social media, where there was a group of female soccer players in the US who didn't have torn ACLs, but they underwent a strength and conditioning program over a year. They then followed them up, and they saw a significant increase in girth of their ligament over time. So this principle that we can actually build strength within muscle also can apply to ligament. So what about the current literature? So when I look at the literature, I'm obviously thinking, okay, well, what's most empirical? And there has been a systematic review that looks at the healing potential of an ACL. Again, if you can't find these, I'm happy to share these with you if you'd like. But basically, it was two Cypriot researchers and a Greek researcher. And they said, look, the ACL tears can heal at least 30, 35%. But the quality of the studies is they're smaller. But it's, I guess the key message for me is they started to look into the research, and they said, well, if we shift the burden of proof for a moment and we go, okay, well, where is the research that says that ACL tears can't heal? And there isn't any. And that's probably where it became a bit more dramatic for me. And they said, look, we would expect that there would be an abundance of evidence suggesting that this ligament can't heal. And certainly from a high quality point of view, there isn't any. So I'm still waiting to see whether there will be any studies that come out. And I do think it's possible that we can, come up with some kind of collaboration where we can look and see what type of tears need what type of treatment. So, and having started to talk about this, I've had all sorts of conversations, and some people will say, look, it's never going to heal the same. There was some research from the late 90s that showed that when you probe it, again, much like that Ihara paper from 96, that it does seem tense, and the collagen does look what we would assume to be and feel like a ligament. And then there's different types of bracing that can be applied. So this particular brace here is a jack brace. So this was a Swiss and US study, not dissimilar to the Japanese one, where they have this force mechanism that basically does a posterior draw on the tibia. And they then did a baseline MRI and then a follow-up MRI. And they also had a comparison arm in this study. So they had a rehab group. The ones that did heal, about 78% in the braced group, had a much better quality than the ones who didn't have a brace. So it's not to say that if you don't have a brace, it won't heal, but your quality is going to be less likely. And so then there's a lot of papers, and for sake of time, I can't really go into all of them, but this is probably one of the ones I would use with patients. It's pretty straightforward, although the English English is as a second language with the authors. It's probably, you can sort of see when you've read it at least once or twice, what they do. So they actually had an unrestricted hinge knee brace. And their idea is that if you keep it in the patient basically in those first 3 months in a uniplanar direction and don't get them to twist too much, you can get quite high chances of healing. So they had 83 out of 102 heal. And the way they defined it, so they would, obviously you do the baseline MRI, and then you do a follow-up MRI at 3 months, okay? And so they would describe the first tear in these kind of main 4 categories. So you have a straight and continuous band, okay? They had essentially 100% of healing on follow-up MRI. So if the tear is when it first happens, if it's minimally torn, but it's still what we would classify as a grade 3 rupture, that's a very high chance. If there's a degree of curvature to it, 95% chance of at least getting some healing, but still predominantly normal. If it's displaced, 75% of some healing, but it's only about 20% that will look normal on follow-up MRI. And then if it's disrupted, horizontally orientated, or unclear, like the ACL basically just looks completely munted on the first MRI, then none of them will look normal on follow-up MRI. But there will be some attempt at healing, whether it be curved or it'll attach to the PCL. But because these patients were braced early and they had the strength, they suggested, well, look, we have to conclude that the ACL can have a high healing capacity. So here's a case of a flip bundle. So, and we've seen this in the cross protocol, and I've seen this personally, where the patients do have a forward displaced ligament confirmed on MRI at 2 days. They then do a follow-up MRI, and it had migrated back. And then they do a 6 months, and it's looking almost normal, and then 12 months, and then 3 years. So there's going to be some new research coming out that suggests that we can actually grade these tears early. So be on the lookout for that. But in terms of the degree of displacement and how retracted it is, and I guess the idea would be that if we can use AI even and kind of predict how this tear looks, what type of treatment strategy we do, whether it be ACL repair, whether it be reco, whether it be a brace strategy, whether it be strengthening. What are we going to do with these types of tears, and can we make it more heterogeneous? So currently the classification would be it looks normal, it looks thickened, it looks thin, or it's completely absent. Okay, and I guess it was serendipitous that I ended up meeting Richard Frobel and Lomander from the Canon study, because they've done additional research into the Canon, and they've seen that of the patients who didn't choose surgery eventually, 60% of them healed. So this was with no brace at all in a randomized control trial. There was evidence of healing, and not only was there evidence of healing, but those who healed were better than the reconstructed and the ones who didn't heal. So in an ideal world, we would want to get patients' ACLs to heal naturally. And then it leads to the cross paper, where this is, I guess, taking off, and there's been mixed reactions to it, and it's certainly burgeoning in terms of the patients that are being included within it. So there's now at least 500 subjects that have gone through with what we would consider a 90% healing rate. And this doesn't include non-anatomical healing. And a significant proportion, like I was saying earlier, of the meniscus tears do become asymptomatic over time. And fair enough, you'd think, well, is it going to actually be similar to their original ACL? The re-tear rates are similar to reconstruction. And even the lower grade healing, so if it looks, even if it looks slightly more sagged, or if it attaches to the PCL, it's similar outcomes in terms of patient-reported outcome measures to a surgical comparison. The only problem is they haven't done a comparison arm, so it's just been this one group that's had this one treatment, and so the inclusion and exclusion criteria is quite strict. Whereas we kind of need to know and work out multi-ligaments versus larger meniscus tears versus the degree, when we kind of classify people into all sorts of minimal type injuries versus maximally injured knees, who needs what. So here's an example of one who saw 3 surgeons, 2 physios, and a sports doctor who was well versed in the cross protocol. And their MCL had ruptured, retracted, and displaced into the joint. They were booked into surgery at 6 weeks post. They also had a horizontal meniscus tear. They sought our opinion, and we said, look, how about we give it, your knee's feeling fine, how about we give it another 6 weeks? We did a follow-up MRI, and she had interval healing, a Lockman's grade 1. Her MCL had actually bridged, and she didn't go for surgery. So she's on her way, and she's seeing also EP and physio. there's not limited amounts of studies. There is good majority studies are showing that there can be healing, and also partial tears as well, which is another topic. The other thing is, what do we do? Do we leave these ligaments for 6? Do we send the person back if it looks healed at 3 months, 6 months? Do we wait 12? I think very similar to reconstruction. If we look at we know that if we send these patients back post-surgery too soon, they get high risk. So these authors actually suggested that we wait 2 years because the ligament hasn't actually naturally ligamentized even at 4 years post-surgery. And so for me personally, as someone who's done thousands of these, I would recommend that if it's looking like it's healed, you don't pull the trigger on sport anytime soon, at least 9 months minimum for me. Now, how can teamwork look? How can it look? No matter what I say, there will always be someone who will come up with what they call the playbook's bingo, which is basically like the study was too small, there's too many or too few comorbidities, the compliance was too low, too low or too high, there wasn't enough subgroups, the patients were too young, they were too old, they were wrong race, wrong continent, background therapy was too good, not good enough, compliance was unknown. My personal favourite, the unspecified multiple reasons. Too male or too female, the intervention was wrong, dose, device, and manufacturer. So there will always be people that will never be able to be convinced. And since a lot of this healing stuff's come out, I've seen kind of, I guess, extremes. I've seen people there was this cross protocol was discussed in Boston, and it was vehemently disagreed with. But then on the flip side, I've also had a lot of more collegial surgeons, I would say, that have said, yep, they've come out and said it, and they'll just step out from the crowd and say they can definitely heal. And then just this week on the NBC, we had like a mass media release that's saying, look, because of the rates of re-injury of reconstruction, we need to consider this at least as an option. I think it's possible to work in a consensus and try to come up with guidelines of how to manage these injuries. Here's a case example of someone that was put in a hinge knee brace. What are those called? Richard splint. Put in a Richard splint in emergency straight away for 4 weeks. Then they saw me. They wanted to do non-surgical. I said, look, let's give it a go. He had a hard episode of giving way and a meniscus tear. He wanted to keep going. I sent him for surgery. So that's one where I just said, look, not good. Here's another one. A 27-year-old male. He had a previous reconstruction, which was good. And then he sustained a contralateral isolated grade 3 ACL, no meniscus tears. I saw him at 6 weeks. He'd had 3 episodes of giving way. I sent him straight for surgery. Like in the first 10 minutes, I said, mate, I think we're done. I think you probably should just move on from this. It's also really important what we say to the patient. If I say to the patient, look, you can try physio, but you're going to need surgery, we kind of set them up that it's not as good, it's not as quality. And so this orthopaedic surgeon here said, look, it's really what we say to the patients that's critical. Shared decision making is huge. You can have good outcomes from surgery, you can have bad outcomes from surgery, you can have good outcomes from non-op, you can have bad outcomes from non-op. And so it's really important that we don't rush the decisions, we let the patient make their choice, and so they don't feel forced. I have seen some harrowing outcomes where the patients felt pushed into surgery and then had multiple injuries. So this case here, she had a hamstring reco, she then hopped off a chair, ruptured the graft, had a medial meniscus bucket handle, then she had a bone patellar tendon bone, then she had a cyclops lesion removed, then she redid the bucket handle, and she's in the room looking at me and she's saying, well, when is this all going to end? I've heard some really shocking communication. Have you eaten today? We could do the surgery now. A bomb has gone off in your knee's exploded. If you don't get surgery, you'll be crossing the road and get hit by a bus, which I thought it's like a part-time clairvoyant as well. Your only option is surgery. It's the worst I've ever seen. I've heard that hundreds and hundreds of times. But I've also heard some really good. Your ACL has healed. This is fantastic news for you, but terrible news for me as a surgeon. So I thought that one was pretty funny. The repetitively unstable knee patient will choose surgery, which I agree with. We don't generally believe the ACL can heal, but if I operate on you right now, you'll be worse. You've been kissed on the knee by a fairy. So if we look at where do I see this going? Like, where are we headed with this? Currently, the system in Australia is very skewed towards early surgical opinion. these are the item numbers you can find. But we don't have item numbers for prehab, early non-surgical opinion, physiotherapy if someone wants to seek it privately, exercise physiology, sports physicians as a specialist, repeat MRI, getting a brace for the patient, post-op rehab early, and even prevention programs, which probably should be the loudest voice in the room, knowing that 50 to 75% of ACL tears don't need to happen in the first place, which is pretty shocking. And we've got potential to save tens of thousands of dollars into the healthcare system. So obviously the recos can go at quite a high value. But if you look at the metadata, even if 50% of the patients ultimately choose surgery, you will save the system hundreds of thousands of dollars in direct and indirect costs, both for meniscus and ACL. So what's the summary? The current trends aren't really supported by high-quality research and evidence. The model is skewed in Australia and other countries around the world towards early surgery, and I guess I'm suggesting that at the very least patients wait and are given their options. Shared decision-making takes a long time. Getting the patients to contemplate, think through their options. They should start with rehab, at the very least prehab. The challenge is sometimes it's only non-medical are the ones who are actually advocating for the patient to wait. And so this is absolutely within our scope of practice, medico-legally as well. And we can tell the patients, look, your ACL can heal, but it also might not. So we can, for pediatrics and for young active patients, I would strongly recommend a repeat MRI. We don't want the patients to have an instability episode and have a second meniscus tear. It looks bad, and it's going to delay the patient's overall long-term outcomes. How's it going to look? Where are we headed? I think we can come together and get this topic on a level playing field. Unemotionally, bracing strategies may be the best. You can't go rogue. So if you start hearing this talk and this information I'm saying, you can't just start doing it on your own. You've got to have people that are training you and consider that there are going to be people who will need surgery. So how do I think it can look? A bit like this. If you grew up in the 80s and 90s like me, Captain Planet, I think it can be a team approach. And I'm going to give you an example here of a team approach where we had a ballet dancer here in Perth who had a ramp lesion. She had a completely ruptured mid-substance ACL tear, an MCL grade 2-3. She was very keen on not having surgery because her mum had surgery. She never returned to ballet dancing. And so I want to just show you some footage of how she went. It's her right knee. So she does 32 spins here. I've counted them. This is after 10 minutes of jumping around on stage, and I don't actually know the names of what they do, but this sort of stuff. There is new research coming. That's a pilot study from Belgium where we can actually sort of it's a surgical versus non-surgical. We can kind of look at, they're going to see, okay, well, what type of patient, what type of injury gets what type of treatment, gets what type of outcome. So it's more heterogeneous, okay? This would be the ultimate trial. Like I said earlier, surgery, reconstruction, repair, modified brace, which is what I typically use, cross brace or rehab on its own. For what type of tear, what type of patient, how can we get the right treatment for the right person? If you want more information, we've got this Facebook group which has really taken off, close to 20,000 members, ACL and meniscus tear recovery without surgery. And we try to present balanced information to the patient so they can make an informed decision. And this has just been published, aclinjurytreatment.com. Obviously, we're going to be wary of misinformation. So this has been published by the University of Melbourne in interdisciplinary collaboration targeted for patients so they can hear a balanced view and they can take their time and assess all of their options. So if you have a ACL injured patient and you maybe feel like they're getting hemmed in or not being given their options, I can absolutely help you. If you can go to that website, often in Perth I'll end up doing a Zoom consultation with the treating therapist and we discuss everything in very cold light of day. And you can also email me if you have any other questions, but I'm happy to take questions now. Yeah.
Kieran, you kind of hinted at that in your presentation, but I just want to clarify: are you doing a non-operative management for spares of the ACL comes with the ACL?
I think that's a good question. I think that we should at least consider it. Based on the systematic review by Pastilides, they actually said it was, even though proximal tears have an increased likelihood, the other tears could heal as well. So currently, as it stands, it's too, kind of like what we were hearing just before in terms of prediction. It's impossible to predict, much like the success of returning to sport. You know, if only 50% of patients can get back to pre-injury level, how do we predict that? It's the same with what type of tear. Yeah.
It's allied to that, isn't it? Is the outcome measure therefore whether the ACL heals or whether it's healed?
Yeah. Well.
Frequently.
Yep. Yep.
Often healed to PCL.
Okay. Okay.
Is that something you're planning soon, or you're planning something like?
Well, do you guys have a particular healing protocol you use, like a bracing strategy? Okay. 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 Yep. Yep. I can. Yeah. So I've got, there's myriad case examples. There's also some of this from the cross protocol where it doesn't necessarily have to be in its direct normal anatomical alignment. It could attach to the femoral condyle. It could be a partial, like I've seen a partial tear. So one of the bundles flopped down, didn't heal, and then the posterior bundle thickened. So it thickened to look almost as big as the PCL. So I've seen all sorts. But really, this also gets challenging because you have strict orthopedic view, which would be that the ligament tests do correlate to functional stability. The metadata would suggest that the ligament tests don't correlate to functional stability. So that's going to be discussed. And you have I had cases where it's attached to the PCL and they've been successful? Absolutely.
It's kind of similar to with non-anatomical ACL recons. I wonder a lot about data is predicting to gravitation, whereby the AP stability, the frequently
Yeah. Well, for sure. And like the last thing you want to do is have a patient who has an ACL that doesn't look normal and doesn't feel normal, and then we throw them back on the pitch in the first game at Buckles. That would be the absolute worst outcome. So yeah, I think really what we need to know is the kind of non-anatomicals that are going to do well and in what type of patient. But yeah, at the moment, I personally don't take as much emphasis on the static ligament test, but in certain cohorts I would. Pediatric, young active. Yeah. 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 Well, there could be. I've reached out to some private insurers and discussed this with them, and do they want to start implementing healing protocols? Didn't get the call back. but so I do think it is possible. Yeah, economically, our system is a mixed model, like you said, predominantly occurring in private, some in public. But I guess with the public, you've got these large on the East Coast. You have this kind of orthopedic non-surgeon or expert physio role where you're triaging. So that can absolutely reduce costs from that kind of point of view. It's the topic of profit drivers is a whole big discussion, but yeah, I think big picture it could. Will it change? Don't know. Do people want it to change? Don't know. Yeah.
Probably got time for one more quick question if there are any.
Would you mind expanding a little bit on what bracing strategy you're using?
Yeah. Okay. So obviously, like I see patients at all ends of the spectrum. So I'll have some patients that will come in day 2 or 3 and they're chatting to me, and I will send them to surgeon mates that I know will give them that balanced shared decision as well. If that's an ideal world, if we can catch the patient early, I put them in a restricted extension to simulate. There's a couple of other Japanese studies where they do -20 or -30, and I'll keep them in that for at least 6 weeks. And the other thing is, Aussies have got a strong drinking culture, right? I'm from New Zealand, but you got to tell patients in real cold light of day, don't go out and drink and get drunk and dance on this leg. Like, you've got to be very clear about. So I'll say to them, look, you can't go walk on an uneven surface. You can't go decide you want to start playing sport again. Like, this is very serious. You need to take this deliberately. So I use the braces, if nothing else, to kind of make the patient realize that they've got to take it more seriously. I keep it on at least for 6 weeks. Some patients that you think are going to be a bit more dodgy, I'll leave them, for 12 weeks, but I'll make it unrestricted from 6. Yeah. And I'm happy to stay back and ask questions. Yeah.
Okay, so that was the first session done. Big thanks to Kieran Richardson. We've got a short